Hello everyone, this is Dr. Arash Hashemi, interventional cardiologist from Irfan General Hospital. The case was done in collaboration with Dr. Arsis Ahmadiye. The patient is a 50-year-old male with a history of two-vessel disease, significant lesion in ramus, which was fixed with stenting in another session, and RCA CTO with JCTO score above 4 with from osteoproximal part with heavily calcification, ambiguous proximal cap, lung, CTO lesion, and erythri. First MRI viability study showed ischemic myocardium in the RCA territory, and the patient was scheduled for primary retrograde approach. So our exercise is bifemoral 7 and 6 French with extra backup guiding 7 French in the left system, and we didn't want to start the right system because there were no promising approach from the antegrade part. We studied the angiographic films, and we had 3 possible pathways for the retrograde part. First, via the septals through the LAD, which were 2 or 3. The proximal one was the most promising one with a very harsh bend, and we had another 2 possible pathways, one from the ramus and one from L6. Both were epicardial collaterals, which were our second and third options. So as you can see, we are looking for the best possible way. This is the best septal, and as you can see, it's a relatively large septal with a good straightforward connection to the RCA. But the problem is the very harsh bend in the proximal part of the LAD, which makes it difficult to enter through here. We started with cyan and cyan blue wires with no lock, and then we changed to filter FC, and with support of Caravel, we finally managed to enter this septal. Tip injection showed a good connection, and after we confirmed a very good connection to the distal RCA, we tried to serve this septal with SO03, and this is the SO03 passage through the retrograde part. And as you can see in the passage, there are a couple of very important points in manipulating the SO03. First one, you have to just rotate it and let it slide with each contraction of the heart by itself. There should be no pushing, and then you have to pull back and redirect, and then wait for the SO to pass. So I will let the slide run for a little bit, and you can see how easily the SO03 passes the retrograde septal. And then after confirmation that we are in a good position with injection, we may try to pass the Caravel through. Pushing the Caravel was relatively easy in the first part. As you can see, the Caravel is going very good, and then after we entered the RCA, we changed the wire to Gaia 2nd, and then upgraded to Gaia 3rd for more support. But we couldn't manage to push the Caravel from this point, so we put a wire in ramus and with anchor balloon technique. Then we pushed the Caravel as much as we could, but here the Caravel was stuck, so we tried deepening the guiding and using a lot of force and time to pass the Caravel. Wouldn't go much further, so we with trapping method we withdraw this microcatheter and then use turnpike LP, which has a more support and penetration force for these septals, and we were managed to pass the turnpike LP further, and then we started on antegrade gear to prepare the lesion and go for the reverse cart. But this is not a good case for reverse cart because the proximal CTO part was too close to the ostial RCA, and the risk of dissection in aorta is high. So our main goal was to try and manipulate the retrograde wire into the aorta without using the reverse cart technique. And also when we passed the retro wire further in different angulations, we saw that there was a very large gap between the 2 wires. So if we want to do the reverse cart technique, we had to use a large balloon, and the risk of the complications were higher, and IVUS wasn't available at the time to check the planes of the wires, and then we tried with different retrograde wires and changed to pilot 150. These are the tries for retrograde wiring. As you can see, there's too much gap between the two wires in this projection. We tried to manipulate the retrograde wire with Gaia 3. We managed to get into the aorta, but we were in subintimal for sure. So we withdraw and try it again. And after about 20 minutes, we managed to finally get the retrograde wire into the aorta. This is Turnpike LP. As you can see, it's advanced very nicely, and this is the anchor balloon in the ramus. And you can see that we deepened the guiding as far as we could to get more support. And this is the wire. So injection showed that we are in subintimal into the aorta, so we had to withdraw this wire. Again, we tried if we could get the two wires in the same plane. Still, there's a lot of distance between the two wires. And finally, we managed to manipulate the retrograde wire with pilot 200, I think, to the aorta. And this is where we get to the aorta. After we got to the aorta, we navigate the wire into the subclavian, and then with a snare, a large one, we managed to grab this wire, which was relatively easy. And this is the grabbing of the wire. As you can see, one operator pulls the wire back, we open up the snare, and then we advance the wire and catch it. It's better to catch the wire from the very distal end if you could, and then we carefully reintroduce the guiding further, and after making sure that the grip is okay, we managed to send the Turnpike LP into the antegrade guiding. At this point, we withdraw the wire, retrograde wire, very carefully, and make the loop with RG3, and then we did step predilation. And as you can see, we avoid injecting any antegrade injection until we have the stent in place, and very small injection just to see that we don't miss the ostium. And then we put the one large 3.548 stent in the proximal part, and another 3.538 in the middle. And after we made sure that we covered all the dissection, this is our first injection. As you can see, it's a very important point not to inject before you put the stents antegradally, because there's a risk of propagating the dissection to the distal part and losing the distal bifurcation branches. So after this, we were not very happy with the distal part. There's a lot of competitive flow still from the left side. As you can see here, the left side has a very good size, but there's a competitive flow, so we did step predilation there. And using a dual lumen microcatheter, we managed to wire the distal part. So at this point, we used the dual lumen microcatheter again. I think it was Sasuke, to wire this branch, and then did the crossover stenting after predilation and step predilation in the branch. We did the crossover stenting from the RCA to the PDA, and this is the images to see the distal part is good. And after stenting from crossover stenting from RCA to PDA, we jailing the wire. So this is where we at. We are not quite happy with this branch, but we didn't want to jump into the bifurcation stenting just yet. We decided to give it some more time and nitroglycerin injection, and meanwhile we wanted to withdraw the retrograde gear as soon as possible. So we did pot, and after pot we checked for the retrograde gear, so we don't have any complication, and we withdraw the retrograde gear. This is the injection through the septal, which showed there is no complication. So we didn't need the retrograde gear anymore, so we pulled it out, and then we refocused our energy on the RCA. So this is where we at. We are not quite satisfied with this bifurcation, so again, using a Sasuke dual lumen, we managed to wire the both ends, and then we did a step predilation in the PLV, and then with using a T-stenting technique, we stented the PLV and we did the kissing balloon dilation and final pot, and this is the final result, which is perfect. And as you can see, we are suspicious to extravasation here, or maybe it's a subintimal hematoma. We used the prolonged balloon sealing in here, and we did echocardiography, which showed no leakage or any precardial effusion, and we finished the procedure with this image. As you can see, both major branch are saved, and it's a pretty good and excellent result.